Welcome to another in Understanding Mental Health, our series on mental health during the time of the pandemic. My name's John Geddes. I'm head of department here in Oxford and also director of our Biomedical Research Centre. And I'm really delighted actually with the way this series is going. Right from the beginning of the pandemic, we identified that mental health was going to be just as big a challenge. And whilst the university, we're absolutely delighted in the way the university has responded to developing a vaccine, coming up with effective treatments for the virus, we've also been working hard on making sure that the population's mental health needs are met. And this seminar series is one of those. So tonight we're going to be focusing on post-traumatic stress disorder. And we've got Anke Ehlers, Professor Anke Ehlers and Natasha Kaplinsky in conversations. The format's very similar as before. What I'd like is for, we'll have a presentation from Anke as before, and then we'll have conversation between Anke and Natasha. And Natasha will also tell us something about some of the work she's done in the area of PTSD and some of her own experiences, which should be very interesting and very informative. So after that, there'll then be an opportunity for further questions, and I'll attempt to kind of sort those out as they come in. So if you could make sure that you put any questions into the chat function, then we've got a backroom team now for making sure that we identify those questions, and we'll get through as many as we possibly can. So I think that probably all I need to do now is to hand over to Professor Anke Ehlers. Anke is a professor of clinical psychology. She's been in Oxford doing really pioneering research on PTSD, post-traumatic stress disorder, for a number of years. Prior to that, she was actually at King's College for a period. But she was in Oxford before that, and certainly when I got to Oxford many decades ago, Anke was pioneering the treatments here at that time. So it's fantastic. Really important part of our team. And Anke is also the lead of the Biomedical Research Centre's psychological therapies team. So Anke, over to you.
Thank you very much, John, and thank you all very much for inviting me to speak to you today. I'll quickly go to my slides and share my screen with you. Yeah, as John said, I've worked in the field of post-traumatic stress disorder and its treatment for a long time, and I'd like to share some of the things we learned about the disorder and its treatment. So what is post-traumatic stress disorder? That is a mental disorder that can develop after very unpleasant, threatening events, usually events that involve some threat to life or physical integrity. And after such events, people may develop characteristic groups of symptoms. The first group is called the so-called re-experiencing symptoms, and they will be the focus of my talk today because they are very interesting effects of the way the trauma memory reappears in everyday life and is very distressing for the people involved. So that usually has the form of very brief moments from the trauma coming back in a very vivid way, and they really feel as if they are back in the trauma at the time. If you have these very upsetting memories, then it is very understandable that people will avoid any reminders of the trauma, and that can become quite generalized. They might even avoid meeting other people for fear they might be asked about the trauma, for example. People with PTSD also have many symptoms of high arousal. They are often hypervigilant for any other danger that they might encounter. They are easily startled, but they also have sleep problems concentrating, and so on. Often they also have quite a lot of negative thoughts about themselves. For instance, blame themselves for the trauma. They may feel emotional numb and lose interest in activities they used to enjoy, and have a whole range of negative emotions, not only fear, but also shame, guilt, or anger, for example. And once this disorder becomes established, then Often secondary problems may also develop. For instance, people with PTSD may feel quite irritable, which then can lead to problems in their relationships, or they can't concentrate, so work is affected. Many become depressed and try to cope with their symptoms in various ways, including substance misuse, which then can lead to further problems. One big message I want to give today is that originally it was thought that PTSD was an exception and traumatic exception were an exception in everyday experience. But we know now that most people will experience at least one traumatic event in their lifetime. And a few examples are shown in the pictures from recent years. So accidents, assaults, natural disaster, and also like you see pictures here from London bombings that we were involved in working with the survivors, for example. Again, the mental health survey run by the World Health Organization looked into this question in greater detail and interviewed about 70,000 people in a whole range of countries, 24 countries. And on average, 70% of people reported having had one of these really very serious traumatic events. And on average, it was actually 3 traumas per person. So showing how that trauma is not an unusual experience. Everybody can have this experience in their lifetime. The most common traumas that were reported were unexpected death of a loved one, witnessing harm to other people, and road traffic accidents. Now, traumas differ to some degree in the likelihood that they are going to lead to PTSD. And the greatest risk for PTSD is involved in traumas that involve interpersonal traumas, interpersonal violence, especially sexual violence. So 19% of people who have been victims of sexual violence will develop PTSD in a chronic form. One other result from this and many other studies I think is important to share is that while trauma can have this effect on everybody, and the symptoms that I have described, the re-experiencing symptoms, for instance, not being able to sleep after a traumatic event, they are very understandable, normal reaction to having such a horrible event happening to you. Not everybody will develop PTSD, and people are really overall quite resilient in that also many will show a recovery, and especially in the first year after trauma, as illustrated in the results from the same study. These graphs are different, represent different traumas, and this is the years after the trauma, and it is plotted here how many % of the people who initially had all the symptoms of PTSD will still have the disorder. And you can see the really steep recovery in the first year. So 25 to 40% will recover without seeking any help and have a natural recovery. So our question as clinical psychologists is therefore, what prevents recovery for those people that don't recover on their own? And our research and the research of many other people in other countries and in the UK have shown that there is certain processes after trauma that can prevent recovery. And the idea that we proposed, which is also the basis of the treatment that our group have developed, is that while the trauma is something in the past, people will, with PTSD, perceive a serious current threat in their lives. And this can be an external threat. So for instance, they feel very much on edge and really expect the next bad thing is going to happen to them. But more common, actually, it is also an internal threat, which means that they feel that the trauma has revealed something really bad about themselves. For instance, they are a bad person, for instance. And this sense of current threat has 2 sources. One is characteristics of the trauma memory. I'll expand on that in a moment. And the second is highly personal meanings of the trauma. And these are very threatening meanings that go beyond what everybody else might find threatening in the situation. I want to emphasize trauma is always horrific and threatening. So what we observe in PTSD, that the trauma has highly personal meanings that go beyond that. And if you perceive a current threat, people understandably do a lot of things to keep the threat under control that they're perceiving. And they use a lot of different strategies. So for instance, avoidance, we have already mentioned, but they may also try very hard, for instance, to suppress any memories of the trauma. But we know that from experimental research that actually if you try really very hard to suppress thoughts or memories, there is a rebound effect, a paradoxical effect, that you actually, these memories pop into your mind more. And so these efforts backfire really. Another example is that they would take lots of extra precautions to stay safe. And so they might, for instance, not leave their house anymore for fear of being attacked. And while that keeps them safe at the moment, it also prevents them from finding out that actually the objective risk hasn't changed after the trauma. There is obviously always a risk in life, but hasn't increased. And the precautions keep the sense of threat going then. And so let me now talk a little bit more about our results on the re-experiencing symptoms. I gave it the title Haunted by Memories, and this is because these moments from the trauma can really reoccur years and years after the trauma. They're usually from very brief moments from the trauma. Here you see some examples, like somebody in a car accident may see headlights coming towards them shortly before the car crash happened, or somebody else might see the eyes of the perpetrator looking through a letterbox before an attack occurred. And these moments from the memory are really very fresh in people's minds, even years after the trauma in PTSD. And they are also accompanied by strong emotions from the time. So somebody would re-experience the fear of dying they had at the time, or the fear of shame they had during the trauma. And that can include also bodily responses from the trauma, such as somebody who was unconscious may feel really faint and when these intrusive memories happen. And so a concept that that really puts it well together is that these memories appear really to happen in the here and now, rather than being a memory from the past. It's like mental time travel. So people actually have very limited awareness at the time that it is a memory that's being triggered, and the impressions at the time still feel true. It also has the effect that the threatening meanings from the time also haven't been changed. So the most typical example is that somebody who felt during the trauma, I'm going to die now, I'm never going to see my children again, will actually re-experience exactly the fear of dying at that time when they have these intrusive memories, even though they obviously now know they haven't died. So we have developed a therapeutic technique that we called updating trauma memories to help really that information sink in, that the trauma is in the past and the meanings from the time are no longer true. So that involves identifying the worst moments of that particular patient's trauma and the meanings attached to them, such as it's going to happen again, or I'm a bad person. And then we work with the patient together to find information that updates these meanings. And that can be by really talking about the story, what happened in the trauma, how the story unfolded, and then finding information against these appraisals or against the impressions and predictions they had at the time. So for instance, somebody who was attacked, let's say or was threatened with a gun, may at that moment feel, oh, I'm going to be shot now, but actually it didn't happen, or it was only a toy gun that they found out later. So then the important step is to link this information that we discussed with the patients to this particular moment in the memory of that worst moment that the meaning comes from, by holding that moment in mind when they threatened with a gun, for instance, and then really bring in reminders of what they know now, so that this information sinks in emotionally. And when we do that in therapy, it is really very, you can visibly see the patient's emotions change in that session. They talk about it being surprising or relieved, that they are relieved. And we also see the re-experiencing symptoms then drop quite dramatically. And I brought this slide along because we had a webinar on sleep last time, and it also shows in people's sleep. So these are results from a study that we did where we had an intensive treatment program where people were seen every day and people kept sleep diaries. And you can see here that after the session where they did the updating, the emotional connecting, the information that they didn't die, for instance, with the moment in memory, we see a big increase in sleep, whereas it doesn't happen in control sessions. So re-experiencing and the hyperarousal improves quite dramatically. Another technique that we use really works really about the triggers of re-experiencing. These are really quite difficult to spot for patients because we often don't have a meaningful relationship with what happened in the trauma. And the triggers are often sensory information, sensory cues like a color or smell or sound or taste that overlaps with something that happened in the trauma, or something they encountered in the trauma, and is powerful enough to bring back these memories with this here now quality. And this is from our research due to special learning processes. Trauma is really overwhelming, so the memory trace doesn't get fully organized, and people really encode a perceptual memory more than a full memory of a trauma. And in order to address this, we work with patients really in a kind of detective work for identifying triggers. And then when we have identified a trigger, so let's say it's a certain sound like a siren, for instance, the sound of a siren, we would then, and the patient might be sitting at home and hear a siren go by their house, and we would then spot that this is an overlap, and then work with them on focusing on the difference between what the siren during the trauma, what they were injured and so on, and all the whole situation, and the siren now in a safe situation in their home and they're hearing it go by. So, and we then work with the patient to learn to direct their attention to the difference and practice that technique, and they find it very helpful. So these are just two snapshots about the treatment, and I'll show you some outcome data. So this is from one of our randomized controlled trials of people with post-traumatic stress disorder. There were 4 conditions. One was a waitlist group where people were waiting for treatment. As you can expect in the chronic PTSD, there's no change, more or less. We had a supportive therapy condition, and you can see patients improved, got quite a bit better, but they didn't get into the non-clinical range of a PTSD questionnaire measure, as you can see here. The treatment that I described, that we call cognitive therapy for PTSD, had a very large effect. People got a lot better into the non-clinical range. And the same result was achieved actually with a daily treatment where we gave the same treatment but daily. And you can see in the first week, most of the treatment happened. So most of the improvement was already achieved very quickly early on. So this is not an atypical result. This is actually what the whole field shows. This is one of our treatment is one example of a trauma-focused psychological treatments. And these are the treatments that are recommended as first-line treatments by NICE and other international treatment guidelines. And this treatment, cognitive therapy for PTSD, is a trauma-focused cognitive behavior treatment. This group of treatment has the most evidence across a whole wide range of traumas. Another trauma-focused treatment, EMDR, is also recommended in most guidelines. And on average, these, as you've seen in the last slide, these treatments lead to really large improvements. So people who have moderately severe PTSD can expect a full recovery. and those with very high symptom levels will go to a mild to moderate symptom rate on average. These treatments are available in the NHS, in the improving access to psychological therapy services, and also in specialist trauma services. One other point I briefly wanted to mention is that there was initially the idea that chronic PTSD can be prevented by intervening early, right after the trauma. Can we give people psychological therapy right away, and will that prevent them from suffering in the long term? And this is really one of the areas that really showed how important it is to do randomized controlled trials. And initially people were trying very brief interventions for everybody, like a 1-hour session of something called psychological debriefing that was basically really telling your story with all the emotion and right after the event. But that wasn't effective as shown in randomized controlled trials and is not recommended by treatment guidance. Instead, a short course of a full treatment for people with high risk of chronic PTSD, like those with very high symptom levels, has been shown to be effective and is now recommended in guidelines. And one other aspect I wanted to say is that if we're talking about events that affect a lot of people, such as the London bombing that we were involved in, it has been shown that a lot of people don't really seek treatment very early on. And so screen and treat programs have been shown to be really helpful in identifying people that need treatment early on and then offering treatment early. Now, my final slide is about the COVID pandemic. I was asked, what can we say about PTSD and COVID? I want to say, at the moment, we don't know. We don't have good numbers. And I want to emphasize that experiencing a trauma, whether it's during the COVID pandemic or otherwise, does not mean that people develop PTSD. They may have no mental disorder afterwards, or they can develop other problems such as health anxiety, panic attacks, or depression. We can expect an increased risk of PTSD, for instance, in health professionals who work in the front line. They are obviously at risk in doing all the great jobs they do, but under very difficult conditions. People with severe COVID, especially if they are treated in intensive care, because the intensive care environment and the physical state they are in may make them more vulnerable to PTSD by loved ones. But we don't really have the numbers yet. But we would expect that all these people could also respond to the treatments I have described. And finally, the services have been under immense stress because now we have to deliver psychological therapy remotely. And that was a worry, but with some training that was implemented very quickly, for instance, in the improving access to psychological therapy services. And the encouraging aspect I wanted to mention is that the outcomes are really encouraging, and we don't see any kind of decline in the efficacy of the treatments. Sorry for overrunning a bit, I'll stop now.
Thanks very much indeed, Anke. That's absolutely terrific. And if I could welcome Natasha to join you now, please. So by way of introduction, Natasha Kaplinsky, as I'm sure everyone knows, is one of television's most charismatic broadcasters. And it's fantastic that you've joined us this evening. And Natasha, thanks very much. So obviously people will know you from the newsroom, but I had forgotten this, but you were the first ever winner of Strictly Come Dancing as well.
I know, there's a trail of sequins that follows me everywhere.
But it's really important, I think, to note that you're incredibly active in the charity world. You know, president of Barnardo's and ambassador for Save the Children. And I mean, very relevant to tonight, I think. In 2014, you became a Holocaust commissioner and led a project to interview 112 survivors, and you're a board member of the Holocaust Memorial Foundation. So maybe we'll hear a bit more about that. Thanks very much for joining us, and maybe Anke and Natasha could now have a conversation.
That's a great pleasure. Thank you very much indeed for including me this evening. Anke, what an extraordinary talk. I, as you know, have a very personal connection with PTSD. Our family were involved in a truly horrific boat accident about 2.5 years ago. And having thought that I'd dealt with it principally, listening to you talk makes me realise that I probably need a bit more help because there's lots of triggers, as you say, that kind of haunt you. Just by way of a brief explanation of what I meant by what happened, 3 generations of our family were on a boat going out on a day trip, and then there was an absolutely monumental explosion. My father, who didn't swim, our daughter and myself were all severely burnt. We ended up being in the water. Our daughter, being 8 at the time, also had a son who we threw in the water to keep away from the fire. And there'd been an enormous explosion in the engine, the boat's engine. We were in the water for 45 minutes, which ultimately helped us with our scarring, but caused a great deal of emotional trauma. And then finally found and taken to different hospitals around Corfu, where we were at the time, and then eventually airlifted home. The physical recovery took a long time. But the mental recovery is taking even longer. And the reason why I was particularly interested in this talk, in the series of talks that you're conducting, was that EMDR absolutely saved me. Because like Anke has been saying, I was absolutely stuck in that trauma. I was stuck on the boat and I was stuck just constantly. The boat was just here and I couldn't get off the boat and I couldn't get past the extreme trauma of seeing our daughter in the water burnt and what was going to happen to all of us. And so I've become kind of evangelical about EMDR and have spoken about it publicly before because I had not known anything about it. And without EMDR, I fear that I still would be completely traumatized rather than just a bit. And so, Anke, what I'm fascinated to hear is about EMDR, more about EMDR, but also the other treatments that you were speaking about earlier on. As I said, realizing that I probably need a bit more of it myself. I myself had EMDR treatment, but then we also made sure that our children had it, and it has completely released one of them, and the other one still needs some more help. So can I start with my first question, because I can see other questions just flooding in, and I will open this up shortly, but at what point, you referred a little bit about when you can have an intervention. Can you leave a trauma for too long, or can you always revisit it? Is there always help that can be received? Oh, Anke, you need to put your, you need to unmute yourself.
Oh, sorry, sorry, thank you. First of all, Natasha, thank you so much for sharing your experience. I think it's really so important to hear people like you speak about your personal experience and hopefully encouraging other people to come forward and seek treatment if they need it. As to your question about when should people seek help, I think it depends a little bit on the severity of the symptoms. I showed initially that overall, like about 25 to 40% of people may recover on their own, but that's more likely when the symptoms are quite mild. So if somebody who's listening has quite severe symptoms of PTSD soon after the trauma, I would really encourage him, like you, to seek help quickly, because that will decrease your suffering sooner and also then prevent further further problems developing. Is it ever too late? That's another question. So we have successfully treated people who only came forward about 20 or 30 years after their traumatic experiences. And the treatment still works. The memory work actually works exactly the same. It is really, as like I mentioned, it's like a time travel. So you can go back to that memory and access it the same way if it's soon after the trauma or later. What takes a bit more time if it's longer ago is rebuilding your life. So many other things will have suffered in the time, and people may also have maybe lost people maybe other losses involved in the trauma. So the memory work is still fast, but then rebuilding your life may take longer if it's so long ago.
And I took great comfort in the speed of the recovery. I was really shocked at how fast EMDR worked for me. Having, had a mother as a therapist and knowing how long therapy can take when you're overcoming issues, to know that actually EMDR, for me, I had about 5 or 6 sessions and it immediately made a difference. It can be quite short, can't it?
And I'm glad it worked so quickly for you as well. I think that would apply to the other trauma-focused treatment as well, because overall, we as a field, as researchers and clinicians, understand these memories so much better now, so that we can help much more quickly than in traditional forms of psychotherapy. So the average duration of the treatment in our studies is about 10 sessions. We allow for more if people need more, but so it's all these treatments that are recommended by NICE are short-term treatments. So that's maybe another important message. You're not signing up for years and years of therapy. Give it a go, and it might take 3 months or so, and it can make a big difference.
I was very lucky that I was able to access somebody very quickly, but how do people find the right person to work with?
Yes, so if you're looking in the NHS, the first point of call would be the improving access to psychological therapy services. They are available all over England, and you can go to your GP and ask for a referral. You can actually, this is quite important to know probably, you can also self-refer. You can Google on the NHS IAPT services and find your local service and give them a call for an assessment.
That's actually a really important point, that you can self-refer, because some people's trauma is so great that they don't even want to share it with their doctor. So thank you for highlighting that. I mean, clearly, the PTSD has been around since time began. It might not have been named as such from the beginning of time, but people have been experiencing trauma since the beginning of time. When was it officially recognized as a syndrome?
Yeah, you might be surprised that it was only in 1980 that the American Psychiatric Association in their diagnostic manual introduced the diagnosis formally. And but you're absolutely right, the symptoms obviously have been around for a long time. They have been given quite a lot of different names over the time in connection with the world wars in the 20th century. There were quite a lot of different diagnoses given, like shell shock, for instance, and soldier's heart, and so on. They might not overlap 100% how we understand PTSD today, but definitely these symptoms were recognized and also treated. But I think one big step in the recognition of PTSD in 1980 was that this is now a very neutral diagnosis. Some of the earlier diagnoses always had some implicit connotation of, like, it's maybe like some weakness of that person who got the disorder, whereas other people didn't. And we now recognize anybody can get this disorder. It's nothing about you as a person. It is just bad luck, really, being in the wrong place at the wrong time often.
For people that don't know how the treatment works, can you explain?
Yeah, I already explained the 2 memory procedures, like the updating trauma memories and the trigger discrimination, but we would also work a lot on working with patients of reclaiming their life. So that could be activities that they have no longer done since the trauma, because that were meaningful or important to them. So just an example, so somebody who was attacked during the trauma might not play with their children anymore, because when the children approach you and give you a hug, that can be a trigger, and they might be quite irritable then. So slowly introducing these meaningful activities that make life worthwhile is important. And then really working on the personal meanings of the trauma in discussion with the patient. So especially if they blame the trauma on, there's something I did wrong, I should have prevented it, or I should have fought back more. So that involves quite a detailed discussion with the patient and really looking, is that really a realistic conclusion from how the event unfolded? And we also work on those strategies that people use that they use to keep the threat at bay, like the suppressing the memories. Or another very common one is ruminating about the trauma. So going over and over in your mind how it could have been prevented, how you should have reacted differently. And that actually maintains the problem as well. It's a kind of not helpful kind of thinking. Or these precautions that people take, we encourage them to experiment with really approaching situations again.
But with EMDR, for me, I was surprised it wasn't just a talking therapy. I was actually holding on to buzzers. There was actually something happening. Yeah. For people that don't know about how that works, can you explain a little bit?
Yeah, so I think all these trauma-focused treatments have an element of really inducing helpful experiences. So it usually involves bringing the trauma to mind, but then also bringing to mind that it's in the past. So I think that is a common denominator, and also working on the meanings is a common denominator. So people may blame themselves and then actually realizing actually it wasn't me to blame, it was an accident, or it was the perpetrator's fault, can actually be quite an important can be important in all these treatments. And also new experiences like really going out and about and doing new things and that you have given up again, and finding out another trauma is not happening. So it's a lot more than talking. You're absolutely right.
John was kind enough to highlight one of the other projects I've worked on recently, which was the huge honour of interviewing 112 Holocaust survivors, who many of whom had never spoken before about their trauma. I'm very interested to know whether or not this kind of therapy might help somebody like a Holocaust survivor come to terms with something that they had buried deep for 75 years and had never spoken about before. Is that too late?
First of all, let me say it. I think it's really important work that you've done, and I'm full of admiration for this work. I think it's never too late, and I would also want to highlight that obviously these people have had shown amazing resilience to really get through this horrible experience and rebuilding a life for themselves. But it might still not have then all of this will not have made the memories go away. They obviously are still there. So I can't really speak of any treatment studies that have been done with Holocaust survivors, but we know from treating other people who have had different traumas and have had similar there are some commonalities in some of the traumas, in that it often involves like dehumanizing experiences and really long periods of unthinkable cruelty and so on. And one aspect we have found there that probably would also apply to some of the Holocaust survivors you talk to, is that you can resist, even if you are the most resilient person and you resist all the horrible experience you have, and retain like an inner sense of dignity and being a human being, despite all of these things that are going on. There comes a point, and that differs between people, where people give up and feel that often can be accompanied by feeling you're not a human being anymore. You're just like an object that's being manipulated by the perpetrators. And we've observed that, for instance, in political prisoners who were tortured, and also in survivors of sexual violence where the violence goes on for a long time. And that can be severely traumatizing. And initially, these people who had this experience did not respond well to the traditional cognitive behavioral treatments. And that, but finding out about this experience of mental defeat, which is often intentionally induced by the perpetrators. And we can in therapy reflect on that. We can adapt the treatment procedure so that we can now treat people with this experience as well.
Thank you for that answer. I know John's going to stop me speaking, but I just want to bring us up to date with a question about the pandemic. We're learning much more, aren't we, about the physical effects of COVID-19. And of course, there isn't the data to hand to talk about the mental effects on our mental health. But do you think further down the line, you are going to be seeing many more people showing with symptoms of PTSD in relation to COVID-19?
I think as one of the disorders that will increase, yes, but we don't know yet how many it will be. We know already from doing some screen and treat programs with health care professionals that there is a proportion of them who have developed PTSD, but again, we don't know the numbers.
Okay, thank you very, very much. Thank you.
And thanks. Hopefully I've come back on. Yeah, I always have to remember to unmute myself. So thanks very much for that fabulous conversation. I mean, that point about COVID is really interesting, Natasha, because we were, you know, when the pandemic started, MQ and a group of colleagues tried to identify the likely sequelae of suffering from the illness itself, and also the impact on the general population. And people did a systematic review looking at the kinds of mental disorders that people were affected by when they'd had similar viral illnesses, the coronaviruses that we've had before. And PTSD was one of the more frequent ones. So Anke and her colleagues have always been sort of, we've just been waiting to see what happened, and they're sort of in the process of seeing if, and I think this is really interesting, whether you could design an intervention that would reduce the likelihood of suffering from PTSD. And one of the big projects that's being done in the UK at the moment is this FOSP COVID study, which is being led out of Leicester and is following up 10,000 people who've been admitted to hospital who've suffered from COVID-19. And we are looking at the mental health outcomes of those patients too. And we're screening them for anxiety and for PTSD and for depression. We've almost got 1,000 patients into that study, and so we can begin to start looking. And then the idea is to look at the data as it comes through, and then if it looks like that's a problem, then Anke and some of her colleagues are already in the process of working out what the interventional study would be to try and improve outcomes.
You might need to include the doctors and nurses in that study as well, because I'm sure they're fairly traumatized by what's been happening.
Absolutely, and I think, Anke, you and Jen Wild are on top of that one as well, aren't you?
Yeah, so we are interested in doing a screen and treat approach, just like we did for the London bombing survivors. I think this is the most effective way of quickly getting treatments to people, and we can also expect, we know that from previous work, that healthcare professionals often are the last ones come forward to seek help themselves. So by doing an outreach screen and treat, we're hoping to help more.
Yeah, it's been a real concern right from the beginning, and as we go into this second wave of the illness, there's a lot of concern about, you know, burnout, and we've got a very tired workforce in the NHS, and so these are really important issues. We better have a look at some of the questions that are coming in, and there's a large number of them actually, but I'll try and summarize some of the ones that I've been having a look at. I mean, Anke, Natasha, one of the questions that's come in is looking at sort of almost different contexts in which the trauma is experienced. So that there's some questions about whether when the trauma occurs during childhood, it has the same kind of effects and can be treated in the same way when its effects become manifest later on. And there was another question about people who've been you know, suffered from immigration and trauma related to that, and whether there are specific issues around. I don't know if there's anything about the nature of the trauma in those sort of ways.
Yeah, I think the trauma that happens very early in childhood of course, may have an effect on the child's development. So being traumatized that early on can make some people miss out on certain developmental steps. But overall, the results in the literature show that the same techniques that I was talking about, the trauma-focused CBT or EMDR, also have the best outcomes for people with who experience childhood sexual abuse. There is a debate in the literature of whether they need additional treatment for more general problems with emotion regulation, for instance, or general differences in interpersonal relationships, because their relationship to other people was disturbed so early on in life. And that is really something we have to do more research on. Actually, the World Health Organization have just revised the diagnostic system to distinguish between post-traumatic stress disorder in a much more tight, like narrow way, and more complex PTSD, which has these additional symptoms. At the moment, the evidence seems to suggest that the same treatments are effective, but the idea is maybe there should be a phase before they start the trauma-focused work, where they work on these other issues. But that's really an open question. So clinicians often favor that idea, but the research so far hasn't really given us the evidence to say that that is the recommendation. And the National Institute for Health Research actually has a call out at the moment for new research exactly on this question. With respect to refugees and asylum seekers, obviously these people have, again, a lot of different traumas, but they often also have this uncertainty that they live with, will they get the asylum or not? And the clinicians, I think, are in agreement to work in this area. We just had a big workshop on Friday where we were discussing this, that even if it's uncertain whether somebody is deported again, it still makes a lot of sense to give them these evidence-based treatment to deal with their previous experience, because it will, even if they are deported, then they will at least go back in a better state initially, even though they are at a risk of further trauma. And my colleague put it in this word, even if you only have 10 sessions, it's still, you can still do a lot of good work with these people. So we shouldn't really deny people like this access to treatment.
Thanks very much. And Dan Duran's asked, is there benefit to an individual's recovery from more collective approaches to acknowledging and dealing with trauma?
Yeah, so I think, Natasha, you probably can speak to this as well with your Holocaust project. I think a kind of acknowledgement of what went on and reflection on it can be certainly helpful. Our personal experience is mainly with, for instance, with the survivors or the community in Omar after the Omar bomb, and there it was certainly felt that community activities were very important in creating a cohesion in the community, and that people found that helpful. It wouldn't replace the individual treatment, or in my view, it would go along with that. But the public acknowledgement would be supportive, and we know social support also helps with recovery. So I would see it in that way. But you may have views on that, Natasha, as well.
Natasha, did anything come out of your conversations with the Holocaust survivors?
Do you know what? I think what Anke's just said is absolutely right. It's the recognition, it's the acknowledgement is a step, but I don't think it in any way addresses the issues. And just knowing about our own personal trauma, you know, we were all on that one boat, and we all had very, very different experiences, and we all needed very different approaches to how we would get over the issues that we faced. So yes, I think acknowledgement, of course, is important, but I think, you know, each person experiences a trauma individually, and so I can't see how a collective approach would work, but I'm not an expert.
But exactly what you're saying, Natasha, is exactly our experience in treatment as well. Even if several people or a large group of people at the same event, everybody, what the individual meaning is of the most threatening moments is completely different. And we also haven't found it helpful to good group treatment, so individual treatment, and that's a result in the field. Individual treatment works much better.
That's very interesting, isn't it? Because there's also a comment in the questions, I think, from Ariadne, who's a mental health professional, remembered after 9/11 in New York, there was some discussion that trauma was deepened and extended by asking those people who experienced the trauma to describe their trauma so often and so quickly after the event. And I think, Anke, you mentioned this in your talk, but it's worth just asking you a little bit more about, because it's all this sort of idea of debriefing. What's the evidence on that at the moment? Is it helpful or unhelpful?
At the moment, that it's not definitely not recommended. And exactly, 9/11 was an example where people really, like therapists, all went to New York to offer a lot of debriefing, because at that time it was thought to be helpful. And I think it's understandable why people did that, because the people that went through this debriefing often said it was helpful. But it was only when we did the randomized controlled studies where we compared people who were offered debriefing with those who were left on their own devices and have a natural recovery, we actually saw that the natural recovery is actually best in getting symptom reduction. So there are some studies actually showing that it makes people worse. And I was in one of these studies at Oxford. Actually, people with who got this one session debriefing after a road traffic accident had worse outcomes at 3 years than those who didn't, if they had quite high symptoms. And there's another study from Jonathan Bisson in Cardiff showing the same with burn survivors, actually. But many studies, other studies, have found no differences. It just has never really found to have any demonstrable benefit and possible actually harm. So it's not recommended anymore. But it's at the time it seemed to make a lot of sense, because a lot of what therapy is about, focusing on the trauma and talking about the trauma. That's helpful if you're further on, but immediately after the trauma doesn't seem to be good. And we don't really know why. It may be because it interferes with the natural decay of memories, like people after trauma will think about it in their own time. They may also go back, they may not only think about the trauma, they also alternate between engaging back in everyday life, getting back to normal, and focusing on the trauma a little bit at the time, rather in this big, like one session debriefing. So that may be one, the memory. It may also be, I think, we have done quite a lot of research on people's interpretations of their traumatic memories. So if people have intrusive memories, some of them may think, oh, I always used to be in control of my life. Now I'm having these uncontrollable memories. That must mean I'm losing it. I'm going mad or something like that. Or maybe I have if they had some injuries, and maybe I have a brain injury now. So these catastrophic interpretations of having intrusive memories may possibly, but we don't have the data on it, just a post-hoc idea. If you have had an intervention, you may think, oh, I should be better now. But then if you still have these intrusive memories coming into your mind, you might be more vulnerable to have these interpretations. Oh, these professionals said this should help me not getting the symptoms of PTSD, but now I'm having the symptoms of PTSD. Maybe there's something really wrong with me. But that's just a speculation.
It used to be the sort of default response, didn't it? I was on call as a junior doctor in Sheffield back in, I think it was 1986, during the Hillsborough accident, and that the entire system was trying to mobilize itself to provide this large-scale counselling and debriefing of people who'd been, in the Hillsborough Stadium at the time. And it did seem the obvious, the right thing to do. But I think it's interesting, Anke, because is there anything that can be done sort of really early on after trauma to reduce the likelihood of developing longer term post-traumatic problems? I remember that Emily Holmes did some work trying to disrupt visual memories.
Yes, yeah.
What's the status with that sort of research? Where are we?
Yeah, so that there were both pharmacological interventions were tested, and also the idea that you can disrupt the development of these intrusive memories, especially if it's visual memories by playing the game Tetris, because it would influence what's laid down in your memory about the trauma. That work has shown short-term effects, but what we really need a demonstration of that, it could really prevent a PTSD. Often these effects were very short-lived.
Yeah.
Anke, can I ask, left untreated, can PTSD last a lifetime?
I would certainly think so. Yeah. So and it might not affect people's life to the same extent all the time, but there may be more vulnerable periods when the symptoms become more prominent. So let's say when people have their own children, for instance, some of the memories from the earlier traumas may come up, and that then become more distressing, and they often actually seek help at that time, because they don't want to be teach their children to be overly cautious and restrict their lives so much as they've done so far.
Well, look, Natasha and Anke, many thanks for talking this evening in the webinar. It's been absolutely fascinating. And I think we've also learned just what a kind of broad range of human experiences this applies to, actually. And there's obviously a lot we do know, and it's just brilliant to hear about the benefit that Natasha had from EMDR and the development.
I think I need a bit more though. I'm going to book it again.
Well, we're always trying to do, yeah, I mean, it is interesting, isn't it, the way that people, you know, I often need top-ups of these interventions, even when they're effective. But also we are making progress, and it's great to hear that. I would like to also thank everyone who's commented and asked questions in the chat. I mean, I hope we've done a reasonable job with that. There was a lot to kind of look at and digest, and there's both wonderful comments of additional resources and other things. So we will try and capture all that. Thanks also to Andre Tomlin of the Mental Health, who's been capturing all this for us. And we'll be editing tonight's webinar, and we will make it available in a couple of weeks on our YouTube channel. So you'll get a chance to have a look at it again. And Anke's going to let us share her slides, so all that will be available. And of course, thanks to Tom Stutterford for helping us put it all together, and to Dora Loewenstein for supporting the development of this webinar series. And on that note, I'll say farewell, and thanks again to Natasha and Anke.
Thank you.
And hopefully we'll see you in a couple of weeks' time when we've got Willem Kijken and Monty Don looking at mindfulness and approaches to mental health problems. So join us then. Thanks, and a very good night to you all. Bye-bye.